as we move on away from awareness and more into the knowledge competency, I want us to take a look at the various competencies of different types of techniques, different types of services that we can provide. And generally speaking, as we talk about this, we're going to look at this in the context of individual therapy, but we also, a lot of these research studies also apply to group sessions as well, and the different effectiveness and efficacy that is there in individuals is also there in groups. And so as we talk about that, I want us to be thinking in that light. Counseling and psychotherapy work, okay? Research shows this, that more than 40 years of outcome studies have demonstrated its effectiveness. So we know that we're not sitting here taking these classes for no reason whatsoever. We know that this stuff works. It's grounded in data. What the data shows, however, is that nearly 50% of clients will drop out of treatment. And there are a few predictors for that, which is the hard part. Now, some of these predictors do include substance abuse. It includes minority status, people who have lower education. These are the folks that a lot of times will tend to drop out early. Now the minority status, the lower education, and the substance abuse, a lot of times substance abuse speaks for itself. The other two, a lot of times are because of potential financial services. They don't have the ability or the ability to afford these types of services, and so they drop out. Or it might be from a minority group. They don't have the support of the family or the culture that they're in, and it's viewed very negatively that they're in counseling themselves, and so rather than facing the negative stigma in their society, they drop out because of that. So as we move on, I want to take a look at this efficacy and effectiveness. One research study found that at the end of treatment, clients were better off than 80% of a control group that did not have treatment. Two studies showed that about 75% of clients significantly improve after 26 sessions or 6 months of counseling, and that 50% show significant improvement after only 8 to 10 sessions. This speaks volumes to both short-term and long-term therapy, that if 75% of people show effective, that they were helped in 6 months, and 50% of people were helped after just 8 to 10 sessions, that what we do does count. What we do matters. But it also alludes back to the fact, are you willing to be able to accept that some people won't change, that some people won't progress? Another efficacy, counseling efficacy and facts, and I'm giving you this for your own kind of thinking through the knowledge of the different techniques that you're going to use, the different strategies that you're going to apply in your own personal counseling setting. I want you to think about these factors and think about these types of these issues, because this will really impact the way that you counsel and the way that you impact and bring in other people into the community in those that you work with. In fact, here's what one research study shows: the average length of stay in treatment is typically those 8 to 10 sessions, with a modal number, however, of 1. And this is interesting. What I mean by that is that there's one session. After one session, a famous research project by Kaiser found that 80% of those clients who dropped out after one session reported they had received the help they needed after that one session. Now, 80% of people who drop out after one session receive the help they need. What in the world are some of the factors that go in to getting help after only one session? A lot of people say that they got the advice they needed. They got what they needed after that one session. Maybe they just needed someone to listen to them. Maybe they just needed to listen to themselves talk about that particular problem. Was it the counselor or was it the client that brought about the change? Who gets the credit for it after one session? We're going to look at that here in 1 second. Counseling advocacy. Relapse is more likely, most notably, with those with substance abuse problems, chronic mental illness, eating disorders, as well as recurrent depression and personality disorders. These more pervasive, kind of deeper personality disorders, the substance abuse, the dual diagnosis, eating disorders, these tend to have stronger relapse, especially if there's behavior attached to the presenting problem itself and the dysfunction in life. It seems, however, that change is more likely to last if the client, this is interesting, if the client attributes the change to their own efforts, they themselves are more likely to have a less incident of relapse. Now, what does that say for us as community counselors? What does that say for us in our own competency skills? What that says is we ourselves want to empower the client. We want to bring the resources in, the people in, to help empower them to have motivation to change. When we do that, intrinsically, research shows that people are more likely to change. They're more likely to make positive changes in their life, and they're less likely to digress or relapse in the various behaviors that are causing them problems to begin with. When therapy succeeds, and this is the conventional wisdom here, the convention is that to attribute the positive outcome to the therapy or ministrations of the therapist. In contrast, when therapy goes awry, or at least yields disappointing results, it is conventional wisdom, or has been convention and customary, to place the failure in the client or the client's personality. That has been conventional. I think we need to understand and know that we are empowering the clients to make change. And we have to do all that we can do as counselors to make sure that we're providing them with the strengths and the resources available to them to empower them to make that change. On a more specific level of research, counseling and psychotherapy are umbrella terms. And I want to look at this because these are umbrella terms that include different types of therapies. Okay? Because research, and this is very interesting, research shows that most models all have the same effectiveness, more or less, just a little bit, give or take a little bit. Okay? So if it's not the technique, okay, there is something else that's in there. And one thing I want to point out here is that there are some types of therapy that are more effective for particular clients, whether it's children or older people, and there's some types of therapies that are also more effective with anxiety and depression, and you want to look at those types of studies that show what technique is better with a particular group of people, because it'll help us then to adapt what we're doing to that particular clientele or that particular people group. But when you look at these particular studies, I want to point out the difference between efficacy studies and effectiveness studies. Because efficacy research is where we study therapies under strictly controlled environments with a control group. Okay? So you're looking at the difference between the control group and the intervention group. Effectiveness research looks at how effective a particular therapy is in the actual practice, in the actual setting. So you use a pre-test and a post-test to look at how effective that was in practice, as opposed to efficacy studies which set them up in more of a controlled atmosphere. So what you could say is that these evidence-based, so you're looking at two different types. You're looking at evidence-based practice, and effectiveness research is practice-based evidence. Okay? And so what you're looking at, effectiveness-based practice will tend to ask, does it work? Does it work? Practice-based evidence tends to ask, does it work in this particular setting? So when you talk about efficacy and effectiveness, that's the two different types of research we're looking at here, and they ask very important questions, and both questions are typically interrelated. And so generally speaking, when we look at techniques and you have a knowledge of different techniques and practices, it's important to understand that most of them, generally speaking, provide the same level of effectiveness and efficacy, give or take a little bit. And it's important for us to do our research on what types work better in different populations of people.